Hi, everyone. I was very lucky to be appointed to host this wonderful panel. Kim is our award winner this year for Early Career Award. And I think that we couldn't be at a better time to discuss global mental health, not only because this is the largest, and I learned today, over 70 million displaced individuals at this time. And this crisis could not be more urgent. And the idea here today is to hear a little bit about the work these wonderful professionals are doing, and then invite you guys to collaborate. I have a few questions for you, and trying to connect not only the work that we can do in clinical psychology, in psychology, but also in education, looking at mothers, fathers, families, children, schools, institutions, governments. So we hope this is a very interesting panel. And let's start with Dr. Verdeli, please.
Oops. Why don't I take this? Okay.
I think it's like,
Huh?
yeah, pull it out.
So, can you hear me in the back? Good. Good afternoon, and thank you for sacrificing valuable free time, rare to find these days, and sunny as well, to come to our session. So, let me clarify something that my global mental health students know and are smiling already. When I say global, I don't mean international only. There are plenty of places in our backyard, here in Harlem and other areas, that are struggling with adversity, with a lot of the problems and system challenges that we see around the world. So this is, I have here a map so to give you an idea where we work. So we have, these are our projects. In terms of displaced people, we worked in Colombia, in Bogota, with IDP, internally displaced persons, women who had to flee, all this, the violence, because mainly of drugs in Colombia. We also, right now, we partner with UNHCR, which is the UN Refugee Agency, and we have a big project in Bangladesh with the Rohingya refugees, the highest number of stateless people, as you said. We work with kids who have been victims of disaster, the latest one, earthquake in Nepal. And we are part of the national mental health response to the Syrian crisis in Lebanon, when we work very closely with the Ministry of Public Health there. So I can tell you a little bit about, the work. I know that you have some questions to structure this, but I'd like Kim to talk about her work as well. Sure, why not? This, let me.
Okay, perfect. So I think this panel is going to be very interesting because the Global Mental Health Lab here at TC is doing so many amazing projects all over the world, and my work primarily focuses on how we support folks once they actually cross borders into the United States. So my work in human rights is primarily working with asylum seekers, although we do work with asylum seekers from across the world, folks escaping persecution because of their political opinion, because of their religion, because of their nationality, because of membership as a member of the LGBTQ community. Today I'm going to focus a little bit more on folks fleeing violence in Guatemala, Honduras, and El Salvador. These are the folks we're seeing very frequently now in the news, and we're kind of in the crosshairs of current immigration policy. So I'll focus a little bit more on that in a few minutes.
Okay, thank you. Well, it's an honor to be here. In the last 5 years at Teachers College, first as a master's student and now as an advanced doctoral student in Dr. Burt Ali's Global Mental Health Lab, I do have the privilege of assisting and coordinating the studies in Bangladesh with the Rohingya refugees and the study in Lebanon, which is focused on both the Lebanese host populations and the Syrian refugees that have been resettled in Lebanon, and looking at how to adapt and then implement and nationally disseminate a focal mental health treatment. I'm also a former corrections officer from India, and in my role as a corrections officer, I was instrumental in launching one of the first gender-based violence prevention programs in the country with UN Women, and then later on working with sex workers and more recently with home-based sex workers in India, where that was the first formative study understanding the mental health needs of marginalized and rather invisible women in the country in very rural regions. So I'll be talking a little bit about that as well.
Okay. So I'll start with a question and then you can take it up. So my first question is, and I'll take it from this morning, let's start with the end. What should we be asking when we're in a crisis situation? So even if it's refugees coming into New York, or if you're going to a refugee camp, or if you're going and seeing a displaced entire population, what are things that you should be asking? Sometimes we talk about everybody wants to help, or what does that look like, and how should we be approaching a situation? What are signs that we should be looking for, and how should we be not making more damage? And I would just jump right into that, and actually helping.
You want me to start? Sure. So I begin to interface with asylum seekers once they have entered the United States, either affirmatively or defensively. So there's many forms of asylum that people might apply for. And these individuals have either entered without inspection, and now that they're in the United States are fearing for deportation and really beginning to do their asylum process under the threat of constant deportation, which is quite terrifying. Or individuals who, upon entering the United States, have interfaced with Border Patrol and ICE and are now being detained, either as an individual or with their children. Or folks who now are in the community and are working closely with a legal team to prepare their application for asylum. So for us, I mean, we're very much, we kind of think of it sometimes, depending on the setting, to be triage. So in a detention center setting, we're working very quickly because primarily we're working with folks who have not passed their credible fear decision and are about to be imminently deported. And our role as mental health practitioners is to meet with them to really identify how the mental health sequelae of their persecution might be negatively impacting their ability to testify effectively, with the hopes that by really elucidating for the court that their memory could be significantly impaired, the ability to tell a chronological story we expect is going to be extremely difficult or problematic or impossible, and or just the experience of being in an adversarial situation, potentially been separated from your children, potentially just being reunited, and how all of these factors can really limit someone's ability to tell their story and their narrative in a way that would meet criteria for asylum based on US law. So that's kind of our function in the most kind of dire settings, I would say.
So when we go after disasters, when we are invited by the UN, WHO, or international, local NGOs and academic centers, we go with the awareness that a number of systems break down, not just the mental health or the health system, but other sectors, education and social protection. So before we go, we try to familiarize ourselves with existing resources in the place. What has been there, what works and worked well. We try to understand, WHO usually does a resource mapping, the 4W exercise, who does what, where, and when. So we need to understand better, the terrain. And we need also to contact coordinating services, local and international. What we see sometimes after disaster is everyone wants to go. Sometimes we get in the way of first responders. Sometimes, like in Haiti, our colleagues, from surgery were telling us at this hospital where we went that they asked for, for surgeries. There were a lot of amputations after the earthquake. And they said, how many orthopedic surgeons? There are 8 people who came from around the world. Any nurse? No nurse. So there has to be, some coordination. Sometimes it's important to find a focal person who does that. In mental health, we should not assume that all survivors will develop severe mental illnesses after even some of the most unspeakable, exposures, because that's not the case. Many people actually bounce back. They struggle for some time, but they bounce back. We need to keep that in mind, not go around and do psychotherapy with everybody. In the beginning, everybody struggles, right? But the mind needs some time of its own and with the help of community to recover. You said it, do no harm. I mean, that's the most important thing. We are social scientists. We also have training to mobilize social resources and interpersonal support, which is perhaps the single most important predictor of good outcome, psychosocial outcome of people, if there is social support. And within the camps, but also from the host community, people usually do well. So use also the crisis, that's the last thing I want to say here, as an opportunity. I'll talk to you more about, we have a very good example in Lebanon. Use this as an opportunity, partner with ministries of health, to build not just vertical boutique systems for just for the refugees or IDPs, the displaced people, but something that serves the whole population. That's very important because there is usually a lot of resentment after this type of situations, and many times the host population is not doing necessarily all that well, right, or much better than the refugees. So we need to pay attention to do something that will benefit the whole population.
I can add just a couple of things. I think for example, in Lebanon, in a project that spans from grassroots to governance, right? It's the engagement of providers and clinicians who are working in community settings and are working in primary care. And then we're also keeping an eye towards policy reform and the support and the buy-in of the government. I think the one aspect that's been very key in multi-sectoral engagement is to see what the expressed need of the community is and then be driven by data. I think there is great merit in the systematic research approaches that have been also developed as part of capacity building in mental health in some of the regions from the lab. And that actually speaks directly to the mission of creating sustainability. If there is the pilot feasibility gives enough outcomes, then you go to the next stage instead of actually going in and launching a large program is what I constantly learn in the lab and the work we do.
I think it's very interesting because my next question was going to be actually about community and people. And it seems that, especially when Dr. Verdeli was saying that, the whole system is breaking down. You have not only the health system, but everything in a crisis situation is not very structured, or maybe it was poorly structured and needs to be thought about. And then let's talk about the power of community. Or maybe you could give us some examples of some work that you have done that invested in that community space, and how do we actually do that, and how that connects with the individuals and that movement. So, your pick.
So the folks that I primarily work with are not individuals who are typically fleeing natural disasters. So the majority of the folks that we end up interfacing with are individuals who've been persecuted in their country of origin. So for these individuals, moving into a host country, joining the diaspora is usually quite impossible for them in some cases, because some of the same oppressive dynamics that they experienced in their country of origin can be replicated in their host country as well. So that can create a real strain, especially since we know how important community is to good functioning for people's sense of self and sense of meaning, and staying connected to the things that keep them strong and resilient. So these are questions we're asking ourselves now. And so one of the things we're considering is, how do we create participatory approaches to gathering information from survivors so that we are definitely creating services that are designed and driven to meet their needs as they see them, while simultaneously hoping that we can help create a secondary or tertiary community that may be the first community that some of these folks have, where they might potentially be able to communicate some of their experiences, where maybe the mental health stigma associated with some of their experiences, or being trafficked, some of these experiences of torture and persecution that have such kind of social exclusionary kind of characteristics associated with them, can be potentially ameliorated by being able to kind of develop a community, maybe not even 100% from their country of origin, but people who might have shared experiences. So for us, this is very challenging, because a lot of the individuals that we work with and their legal teams say again and again, isolation is one of the most difficult things a lot of the folks that we work with are experiencing because of these reasons.
Actually, let me talk to you a little about our work in Lebanon and what's happening. So there is now policy, there is a 5-year strategy for persons affected by the Syrian crisis. And the picture is of our very close friend and collaborator, Abil Shamai, who is the director of the mental health unit of the Ministry of Public Health. So there is a human rights approach that the policy has, and for me it was a very good lesson of how a top-down strategy can work also with a bottom-up and meet. The principle is that everybody who lives in Lebanon should have access and enjoy excellent evidence-based mental health that is accessible and community-based. And everybody should benefit from this, right? Host population. So what we did here, Lebanon has been, as you know, incredibly burdened by the crisis. 4 million people with 1.5 million refugees. It's like Mexico coming to the States, basically. That's the magnitude of this. So what we have been trying to do is also develop communities of practice and let ourselves be educated and guided by the local experts, by our colleagues there, who know a lot about the population. So we have a collaboration, we set in motion a collaboration among experts. We always try to understand, local idioms of distress, how people express their despair and unhappiness, what are some of the things that they found useful in their own practice, and always think about sustainability. We get guided by our local colleagues. So there are a number of communities that we are dealing with, of the local experts, and also the communities with the refugees and the host population. It's important for the host population to know that services are created with, of course, as a trigger was the Syrian crisis, but they will benefit from that. And I think that was a very good idea.
I think that these were also very interesting. So I'm just connecting a little bit with what I've been thinking lately about this. So Brazil has recently had a few pretty dramatic natural disasters, and the most recent one about which were not natural, and we don't say because they were just a lack of responsibility from a company. But right now we have a place called Brumadinho, and we had a massive mudslide, and about 200 people are still missing after 2 months and I'm not sure how that's going to go. But it was a small community, and that community has been not only destroyed physically, but we have 20 schools that have children that have been affected directly, that have children missing, that have teachers missing. So I was going to bring this back to you as an educator. One of the things that I look at is how do we start helping this population that is there. And you can see this also in refugee camps. So the children that are there, how do we start approaching them? How do we not only look at the crisis and the mental health and what's going on right there from the start, giving them language to cope, or how do we do that? But especially the families, because they also have to give that support. So just thinking about community and that systemic approach, and thinking about education, how do you see, or how have you seen in different scenarios that happen, and successfully and maybe unsuccessfully as well, so we can learn from those mistakes?
Actually, we have one recent one in our backyard. It wasn't, it's in a high-income country, and that was relatively recent, 9/11. And we learned a lot from that, and we learned what went right and what went wrong, what happened, what didn't happen afterwards. But some things, because it's our culture, we didn't approach it with, fresh eyes. We didn't ask the questions enough, I think. I was, still training at that point. But many experts from different centers went there, didn't ask, the local centers and the local, colleagues there what they think. They didn't. So one of the things that we now know that should have happened more, although some colleagues who live there actually started doing the work, is a lot of psychoeducation of the families. Because, in the beginning, there is the united, we are, after a disaster, but when, after a while, adrenaline goes down and we start processing the trauma, and the body is still in this, state of fight or flight, there is irritability, there is, loneliness, so couples start fighting. And there was a tremendous, very high rate of divorce in those areas among first responders. We found out a lot of substance use. So there wasn't a lot of, as much as needed, and now we know that, and we can do something about that, if, in other areas. In preventive intervention. But always, we learn to partner and be humble and learn. For example, some partnerships that may appear paradoxical have been very fruitful there with the traditional local healers, right? So with a child especially, I feel that we need to ask youth more. We ask to everybody else except young people. And I remember in Sarajevo, some colleagues were telling us things were incredibly gloomy and people were struggling a lot. And they asked the kids, like, what do you think, will help in the community? And they said, Mike Wessel's work, they said, actually, people hate the food here. One of the things they hate. They give all these foods that, that they're not used to. And so what can we do about that? So they started talking as a community, what are we going to do about that? I said, well, how about cooking the things we know and we can all help? And it was like, he describes like an almost Fellini-esque scene, where people are cooking, they're enjoying it. So there are sometimes little things that play an enormous role.
Well, I can also jump into the next question with the little things and the big things. So one of the other curiosities, at least, and I think that it's interesting because I know it's a point of debate, is about the language. And maybe Kim can talk about this, especially people coming into the United States seeking asylum or immigrants coming in. When you're working with these individuals, what is the room of language and culture, not only the culture that they're being exposed and coming into, but the one that they're coming from? And in your case, like you said, maybe there's a third culture that they're going to have to create around those identities. But especially, I think, language, when we're talking about English, or when you're talking about these big crisis situations where they have to come up and incorporate new culture. And kids that have to do that, I think I've seen a lot of families that move and then they say, no, don't speak your native language anymore, just speak English because then you'll be fluent. And I used to see this in New York City public schools when not 5 years ago. So my question for you is, what is the role that plays? And I know this might be a long question, but your perspectives on it.
So this is something that I think we really struggle with in our work because we have to communicate someone's experience in a way that's going to be understandable to the legal system. And we also use a diagnostic system that is very US bound and that doesn't always effectively capture people's experiences. I think also to Dr. Verdeli's point, people don't always even meet criteria for a particular diagnosis. And although sometimes that can be distressing in a legal context because one of the things the legal team is hoping that we can do is document the persecution if there tends to be evidence for it in terms of our interviews. So it becomes very challenging because we most frequently use interpreters, even if the clinician is a native speaker of the language that the asylum seeker speaks. There is still a preference for an interpreter a lot of times because it kind of sometimes acts as a catch and they can make sure that they're not missing something. Their thing is we're taking notes very quickly. So sometimes having an interpreter present just to kind of slow the process down a little bit can actually be very effective in terms of process. However, one of the things we really struggle with is indigenous languages because it is extremely difficult to find interpreters, let alone certified medical legal interpreters who speak Mam and other languages that a lot of our asylum seekers from Central America coming from indigenous communities speak. So it can be very problematic having someone kind of translating their emotional experience into already a second language, and then having an interpreter then translate it again into English for the purposes of a legal proceeding. We know we're losing things. So I think as a clinician, one of the things we're so mindful of is trying to be as attentive as possible so we can capture all the other ways that people are communicating their experience to us nonverbally, and try to, using our own clinical judgment, fill in the gaps. And also, as much as possible, understand, similar to what Dr. Verdeli had mentioned, idioms of distress. So that if someone says, you know, my soul hurts, we can try to help, you know, a judge understand what that could possibly mean for someone. So it is, I would say it's one of the most challenging things we encounter all the time.
I just wanted you to talk more about idioms of distress. That just seems like it's something that we should all be learning how to look at, understand, talk. And this is just an extra question for you. Just maybe tell us, could you give us an example of one situation that you were able to catch that, and what are some things that we can think about? It just seems like it's such an important, as a teacher, I think I should be learning a lot about how to read all of these signs or to read these forms of communication. So maybe this is just a question for all of you. Be brave.
I have, excuse me, I have so many thoughts on this one because there's Dr. Verdeli's voice in my head. And she would always say,
It's a good voice.
It's a great voice. It's a stern but very calm voice, and it says, you know, you're being guided by not just, and I'll quote you. You say, well, not just the linguistic but also the conceptual equivalence, right? And this is how she teaches, and it's like you have to remember that. So many a times, as someone who speaks several South Asian languages. In a recent, I was reminded of one of the trainings that Dr. Verdeli was doing with supervisors. These are clinicians in Bangladesh who'd be eventually providing a mental health intervention to the Rohingya refugees. And we spent several hours thinking about, you know, how would we have a depression checklist that we'll be using. There are tons of questions on it that will ask about their depression symptoms from the week. We're like, well, okay, so this is how we'll ask the question. And they're like, no, there's no word for depression as such. So it's like, okay, let's leave it for now, and we'll come back to it. So the following week, when we did the training again, they eventually came up with this very interesting idiom that the Rohingyas use that transliterates to a bad heart. Not a heart that would be punished, but it's a heart that's in suffering. And that reminds me of how the country I come from and the language I speak, we would say a very nervous mind. So, and who's to say what that means, right? I mean, that's not the depression as we would diagnose it using a DSM, but the very fact that I'm able to articulate that idiom gives me, and I've seen clinically with the patients who feel we now have something to identify our suffering with. And I think there is great power in that. Yeah.
And some of the work that Srishti has done, and it's actually the biggest point of departure of our studies, is qualitative ethnographic work. To learn about this, to ask questions, to understand, you know, what people mean by squeezed brain, for example, or the brick, you know, on my chest. Or in Nepal, we have the kids who are saying the heart-mind problem.
Yeah.
And the bad heart, the heavy heart, and the self-loathing, you know, these syndromes. In northern Uganda, actually, we found out something that I'm sure you have seen. Kids didn't just have depression or just anxiety. They have something that we see as clinicians in other areas. This mixture of externalizing symptoms, conduct problems, behavior, and anxiety, and depression. So we first need to capture, understand that, and understand the language and how it's expressed, and find, you know, metrics, right? Instruments and metrics. We pay attention to the content of the instruments, but one of the biggest sources of difficulty is also the response options. Like we ask, more days than not, nearly every day. So people around the world don't think that way. So we have to, you know, think about how they could understand with visual analogs or other ways to assist.
I think it's very interesting, the data aspect of the research that you're bringing, and that's extremely important, because if we want this to be not only replicated, but these measurements actually be taken seriously everywhere around the world, that's so relevant. And to see the little bricks that you have to actually pay attention to, from the scale that you use in the questionnaire to build that up to the language, it's really remarkable. I'm gonna make one more question, and then you guys are gonna have a chance to ask a couple. And my question is about hope. It has two parts. So first is, what gives hope in these situations, in these dire scenarios? What are the things that will bring these people, these children, these families, hope when they wake up every day in such dire conditions? And also, is there hope in actually working with these populations and making this systemically, so that we don't have 70 million displaced people? So, just a little.
Sure. There are many levels of hope. I think hope is the necessary condition for people to recover. If people don't have a future orientation, they are not going to have any motivation to, fight for anything. Things that give people hope around the world, even this is the Cox's Bazar refugee camp in Bangladesh, where we are going when we get our visas from the government with the UN. 900,000 people live there, stateless, in very difficult conditions. So some of the things that give them hope are things that give everybody hope. Dreams about their kids getting education, that's a very big source of hope. Things, about finding a life, dreams about making some life in the new place. It's unclear what's going to happen with especially this group of refugees. But, hope is necessary but not sufficient condition for people to recover. They need very specific, access to resources, right? Skills. So when we see them, we usually see people who haven't been able to recover, from the help of the community and religion and other things. So they are in a state of hopelessness and helplessness. And there are some basic principles that we have found that help people get out of this state, helping them having options and helping each other come up with options, or if they feel stuck and cornered, try to identify who has more power and try to engage that person, find advocates, breaking the social isolation. And sometimes, these, strategies start working and people, it ignites people's mental health immune system. That's how I think about it. But many times we hear things like, what hope are you talking about? I lost my husband and son, right? Give them back to me. I mean, without, we respond at this point, I wish I could, I can't. Nobody can, nobody will take your grief away, but what we could do is to help you become stronger, to carry this grief and their memories and honor them throughout life. So how to strengthen people sometimes, although we wish we could, make everything better for them, but even strengthening and helping each other In the community we do group therapy usually. That I find very healing, and the results of our research indicate that.
So for us, I really believe that resilience is contagious, like hope is contagious, and that I think that what I'm surprised again and again about is how hopeful people are that I work with sometimes after we kind of discuss their narrative of their experiences, and then we talk about what's getting them through their lives, and people can light up so quickly talking usually also about their children, about their faith, their connection. For many of the folks I work with, their darkest moments is when they feel like they lost that connection to God. And so when they begin to rebuild that connection, that brings a lot of joy into their lives. But I think something that Dr. Verdeli said that I really agree with is that you can't maintain hope like in a vacuum. So one of the things we try to think about is connecting folks to continuity care services, whether that's temporary housing, whether that's food, whether that's classes, whether it's job training, so that that hope can continue to be, those little embers can continue to be fed to keep them going, because I think it's a whole lot to ask for someone just to sit and just hang on to hope in light of so many experiences they've had in the past. And then, to be completely honest, with the current social political climate in which we live. It's a very terrifying time to also be in this country, even if you might in some ways feel a sense of relative safety. And then the other piece, of course, is then the people that are left behind, and how you, in light of your hope, a lot of the folks I work with talk about continuing to hold fear for the uncertainty of the people that have been left behind. And I think it's a really delicate balance that they forge in order to get through day to day. And the hope is, of course, that asylum will allow them to have derivative asylum for their family members, but we know that's getting more and more complicated, especially with the folks that I work with, due to current constraints. So it's difficult, but they are very hopeful regardless, which I think is really extraordinary. I don't think I could maintain that level of hope with such consistency.
No, so I'm just reminded of a very humbling experience of a few years back, and this was she was a sex worker, this woman, and it was a mere interaction of what are some of the mental health needs. It wasn't even an intervention, and interestingly, that was the only life that she had known about, living in the margins, being so invisible, and experiencing adversity in very difficult ways. And she says, this is what God willed for me. This is God's will, and so I must suffer, and I must endure this pain and such. And the question that I had for her was something along the lines of, well, I know that this is, and again, it was in one of the conversations with Dr. Verdeli, I was like, well, it's God's will. What can I say to that? I do want to be able to honor her suffering in the way she makes meaning of it. And the response that came out of me to her was, well, if this has been God's will, so can your health be, right? And so can you getting better be. And it might as well have been God's will that you and I have met. So there is that part of it which is what taught me how to identify her way of making meaning of hope, her way of making meaning of change and improvement. It wasn't my perspective, it wasn't my worldview, but it was hers, and that taught me that, okay, if there are things that she will never be able to undo that she wished she could change about her past, but the very fact that she started thinking about her daughter having a different life, her son becoming a more sensitized gentleman as he got older, those were indicators that that's how she started to think about hope. Just got reminded of that. Yeah.
This is such a powerful thing to think about hope. And I love how you said, it's hard to get hope in a vacuum, but maybe a small conversation can spark it. And I think there's nothing like classrooms, and there are lots of teachers here for us to see this every day. And there's just hope about their universe of things that go on, from fights at home, and then maybe if I could just pick your brains a little bit more and ask you if you have a story of hope, like the one Srishti just shared with us, but maybe something that we can all look at our daily practices, or look for. How do we maybe find someone that is in pain? We're talking about feeling loss of hope, and help that come back in, and then do that in small scale or in ginormous scale like we need. But maybe you have a few stories. I'll start over there and come this way, so I have time to think of one.
So one of the most touching stories recently, last year, came from northern Uganda. We have now a randomized controlled trial. It's a cluster randomized trial with a food program to understand effects of a culturally adapted psychotherapy on women who have perinatal depression, and the effects on nutrition-related behavior and the nutritional status of the child, right? So we work with a food program, and we are testing this right now. The treatment is interpersonal psychotherapy. It has been used and adapted heavily for cultural relevance there. But some of the mothers were also, this is a post-conflict area up there. It was one of the worst complex humanitarian emergencies for 20 years. A lot of displaced persons, a tremendous amount of violence. A lot of people have been abducted as children, children soldiers over there, etc. And I remember, so there was violence, domestic violence, a lot of domestic violence. And many women were unbelievably depressed and suicidal. And they're talking about their child. Then they started coming to the sessions and helping each other. And then, you know, one was saying, and I'll never forget that, it touched me so much, about feeding the baby, breastfeeding the baby, which is something that the World Health Organization encourages and it saves lives. She said, initially I didn't want, you know, I was crying because of what my husband was doing, and the baby, I didn't want to look at the baby couldn't latch on, I would feed once, twice a day. And now that I feel I'm going somewhere, and the women were saying, I feed him much more frequently now, 4 or 5 times a day, and the women say, our babies are beautiful right now. I mean, this I found very touching, how, you know, the way they see the world can change, and how also this benefits the next generation, not just one generation. It trickles down into the whole household.
In terms of like the success of the intervention that we have very high rates of success when folks have participated in an evaluation, because typically they don't have any physical evidence that documents their experiences, and they have to prove it. So one of the things that I think brings us a lot of joy and a lot of meaning is the fact that, especially in New York City and in other parts of the country as well, the rates of being granted asylum 3 times greater if someone has this piece of paper from a doctor that documents either the physical or mental health outcomes associated with their experiences. But on a more kind of personal human level, I think that one of the things I see again and again with a lot of the folks I work with is as soon as they get to a certain part of the process where they've kind of found their sea legs, usually one of the first impulses is then to help someone else. And I think that is something that is just, even in a detention center setting, you know, as soon as someone kind of learns the ropes a little bit, they suddenly mentor everyone else who's coming in. And I see that both in the community setting and also with folks who are currently being detained. And I think that really speaks to generosity of spirit that people have and they can continue to have despite their experiences. So that's something that just really buoys me in terms of feeling hope, even if we don't know what the next day will bring for a lot of these folks, even if we know that some of them will be returned to their country of origin, and chances are it's not going to go well. So that's something that I see again and again that I find really extraordinary.
You had a chance to think about yours.
Go ahead.
I started this.
Oh, okay. Well, I actually did have a chance to think about. Last year, I participated. We developed a program that helped high school students in vulnerable areas in Rio to develop an ethics discussion in their peer groups. And there was this particular student in this very, very tough area in Rio. It's a favela that has 140,000 people living in. And it's one of the most violent places in Rio, which is already probably the most violent place, urban city, that's not at official war. But this program actually just talked about, it taught the children how to talk to each other about their own problems and about how they could learn how to live together in the spaces that they had. And if there was something that they could do, if there wasn't, but just that they acknowledged where they lived and started a voice. And there was this one student who was that student that he just couldn't be kicked out of the school because he had been kicked out of all the other public schools in the area. And then this school, the teachers don't even go, so there was no point in kicking him out. But he went through the whole program, and in the end, there was a celebration and an award. And his classmates and him, they won it. And I'm just gonna get emotional now, but I remember that he said, where I lived and where I'm from, always told me that I wasn't going to be able to do any good for anyone else. I was always just going to be trash. And just learning how to say my name taught me that I'm not trash, and there's a lot of value in what I'm from. And he used those words in Portuguese, and that is just a gem of a student that had been marginalized by just regular situations. And I think it connects with what you said about global doesn't mean in the other side of the world. It means here in our schools, in our room. There might be people here that actually might need a little bit more hope and agency and room and support. So I just thought about that story connected with both, we know, the changes in the community and also the support. But that gave me hope, and your work gives me hope. So with that, I'm gonna ask if you guys have any questions or comments. And I know everybody looks so serious. Come on. I think this, when we're talking about, and if you have, just raise a hand and you get a mic. But talking about mental health is usually, people just think that that's going to be, I think it's a big taboo that we're just not even talking about it yet in the same level that a lot of things are very visible and you can talk about them. But just mental health is something that's still pretty much hidden in very closed spaces. And it's, like you said, it influences everything. It influences how you see your baby. So that's just a good discussion. I'm going to keep talking if you guys don't have any questions.
I was just wondering about the kind of impact that from different kinds of circumstances, if it's, you know, someone who's, or populations that have been persecuted, or, you know, or very bad natural disasters, does that vary in terms of the kind of impact that you see, psychological impact, and the outcomes, the resilience? Do they vary?
That's a great question.
Or are they across different kinds of traumatic events?
You know, usually a lot depends on the amount of resources available to recover, right? And the support they have. Also, if it's natural disaster, you know, people tend to recover faster than if it's, you know, a man-made, right? Man-made disaster and attack. But we see differences, we see cultural differences in that, but the more differences depend on, from actually also, we have a colleague, George Bonanno, who does a lot of work on resilience, and having access to resources really determines how well people will recover. And support of the community. We saw that after Hurricane Katrina, actually. So people, you know, groups of people went everywhere in the States. And Sandro Galè and his team from School of Public Health, then he was at Columbia, did a study to understand who, you know, who does better, which communities did better, worse, and what contributes. And the most important predictor was the support of the host community and the cohesion. Right.
And then I'm going to maybe give that back question, like the support of the host community. And in case of man-made disasters, sometimes it is a member, or in the case of Brumadinho, it was the main resource, financial resource of the whole community that provoked the disaster. So and maybe that's a question back to you, what is the best approach when you're in a case like that, or when you even see crises like the Rohingya people that are being forced out, and their generations that are being massacred along the way. But there is your official home supposedly is the one that's betraying you. What are some of the ways that you've seen and have worked with interventions with those populations?
This is not something that happens interpersonally only, but it's a systems level type of, you know, intervention, which is restorative justice type of activities, like truth and reconciliation committees, right? To have reconciliation, you need to have truth first. It's quite complex. There was study showing that these type of committees are very good for, you know, the community. Individually, people who participate in the proceedings may be doing worse, actually, because of reactivation of the trauma. So it's quite complex. But the need for, you know, restorative justice is really very, I think, very important. And creation of narratives with the communities that remained, and communication, one big issue is the new generation of leaders from these communities, right? And how to develop new leaders from the youth, and what type of role models they'll have. So that's another very promising, you know, area.
Hi. I have a question about the Global Mental Health Program. I know that it's like maybe a certificate or as part of a program. Is that something that you can do even if you aren't enrolled in a program, or do you just kind of take it class by class? Because I'm interested because I work for a international boarding school, and we're often put in situations in which we as the guidance counselors have to, put someone's suicidal child in inpatient treatment, and the parents don't believe in mental illness, and then also the parents have to pay the bill out of pocket for inpatient mental health treatment.
That's a good question.
That was an easy question. I think you're in the program.
We have, the master's program, but we also have a more versatile, shorter institute. I'll give you more details. There is a summer institute in global mental health where we actually work with the Peter Vandervogel, who is the mental health director of the UN Refugee Agency, UNHCR, who teaches ways of identifying, distress. And also we teach this psychotherapy, that interpersonal psychotherapy that we have used around the world, and we give it to the World Health Organization. Now they distribute it for free on their website. They took our manual. So we train in that, and we have about suicidality, which is a very big issue. We actually have a module on how to recognize and assist in developing, safety planning that would make sense locally, because that's with limited resources. Sometimes neighbors have to step in and help. We can talk about this. Do you have the training programs perhaps?
Yeah, I mean, unfortunately, our training programs right now primarily are focused on licensed clinicians, which I know you will be, or you are very soon. Yeah. So, so our focus right now is primarily looking at how to train folks to document human rights violations, and we welcome any provider or someone who's soon to be a provider to come and join us for free training. We adhere to the Istanbul Protocol, which are the international guidelines for the documentation of torture and ill treatment, so we can teach best practices, definitely speak about the mental health and medical correlates of torture and ill treatment. We have gynecologists who can talk about, specific types of harm to women, as well as doctors that can talk about the impact of, for example, positional torture on the body. So we always welcome folks to join us. It's free. And if you're interested, we also provide free mentoring and shadowing, because we really want to increase the capacity of our field to be able to do this work. Yeah.
I will send along all the advertising and how to register for the Summer Institute and such. Then,
Yeah,
yes,
absolutely.
please.
Any other questions? One last question. Well, we're actually almost up, so I kind of wanted to just do a catch-up and then ask some final words, but I was just looking at my notes, and I will share them with you if you guys want. But we talked about language, we talked about idioms of distress, we talked about hope, a lot about the state of mind and the interdisciplinary actions that need to be done. And I think one thing that happens at TC is that we actually host, just at this institution, so many of these areas, right? You're saying we're bringing in not only educators and psychologists and practitioners, but we're bringing in doctors and we're bringing in lawyers. And I think that my last question, and maybe just the last run around for you guys, is how do you see us, what's the next step? And if we could ask anyone at TC or the departments or society, what should we all be trying to move forward towards? And then maybe this is our wish list, our wonderful bucket list of things that could happen.
Thank you. Perhaps, finding ways, feasible and sustainable and scalable ways to make mental health services available. Because sometimes we think stigma is the most, important obstacle, but it's not actually. Studies showed that if there people have access to services, and they realized from their community that people who use them are feeling better and functioning better, people start demanding for them. So how can we have them in a way that are feasible, locally relevant, acceptable, accessible, and scalable? I think this is the big, for me, the quest at this point.
I think something that I remind myself of again and again is something that's been brought up a couple times, which is refugee health is New York City health. If you work with an immigrant community, you will be working with refugees and survivors of torture. And one of the things we know we're actually very bad at is actually assessing which members of our community have had these experiences. So I think it's something that just in our assessment of individuals, even folks who are not coming in for torture-related symptomology, just to really ask questions about people's experiences, because the vast majority of folks in a few studies said that people never even asked them. Their physicians never even asked about their experiences of ill treatment and persecution. And I think when we fail to do that, we fail to really acknowledge the potential impact these experiences could have on people's health and well-being moving forward in their lives, as well as an opportunity to really validate a potential very important experience of their lives. So I think, just constantly thinking about this and realizing, you don't have to go to a refugee camp to encounter people who've survived some of these experiences, that they're actually in our community and they're moving about us and we're working with them, and we might not even realize.
Because the question had the word wish list. As a TC student, I think that global mental health can feel sometimes rather overwhelming or mystified or sensationalized, portrayed in a very different way in many different media platforms. And I think the one thing that I continue to learn as a TC student is the great privilege of having the mentors, the resources, the classes that I take, the advisement that I receive, the supervision that's so formative, but to be able to go after it, to be able to chase it, because the resources are here. I mean, both of you are here, and there are tons of others who are readily available to kind of train and teach, not just humility, not just research methods, but also how to approach it, in our personal, but also in our academic lives. And I think that this is none of the topics or none of the questions that were brought up today are small. And so it's not like it will take an army to start making the change. And I do believe as a student and as a researcher in training that TC is that army. And so I think there's great merit in seeking out those opportunities and beginning training early. Yeah.
Wow, with that note, thank you to our panelists, to you, to our army that's here ready to change the world. I appreciate what you're doing, and thank you very much.